One. So certainly appreciate you all, appreciate the time. As you know, you're kicking off a very important series for the Advancement League, our career series, where we hear from amazing individuals like yourself in the industry and outside of the industry, not only offering career like tips, but also giving our audience and members insight and kind of an inside look at the topic. And today is all about population health, which is broad phenomenon, value-based care, population health. Couldn't be more excited to have you all on. And with that being said, we'll kick it off for introductions and start with Latasha.
Sure. Hi, everyone. My name is Latasha Bardwell. I don't know where to start. My current role, I work at a system of federally qualified health centers in Baltimore City as the director of population health there, where I oversee some of our outreach activity for our value-based care contracts, as well as our community health worker activity, and just building out that program and making sure we have individuals available to meet the social determinants of health needs of our patients. And I also oversee a number of grants ranging from HIV to colorectal cancer screening and beyond, diabetes. I just finished my second year of my DRPH program. I am a DRPH student at Johns Hopkins Bloomberg School of Public Health. I'm also a fellow there under the Bloomberg American Health Initiative, or also known as BAHI. And in that program, I'm under the substance use and addiction track. And so all things substance use, I do support in my organization. And so that's a little bit about me.
Nice, thank you. We'll kick it over to Brent.
Hey everybody, I'm Brent Ling. I'm the Chief of External Affairs at Wholesome Wave. This is a position I just recently started, so the organization's new to me. Wholesome Wave helps with healthy food access programs and integrates those with healthcare. So basically trying to figure out how to match a proper dietary intervention and avoid a prescription or other kind of worse outcome. I'm also a Hopkins graduate. I'm a policy person. I've been in DC in the health policy landscape for 5 years now. I'm working on food, agriculture, and health policy. So glad to be here, glad to be a member of Advancement League, and thanks for the time tonight.
Awesome, awesome. And last but not least, Kwame.
Hi, my name is Kwame Liddell. I'm currently the director of Optum Orange County, Southern Orange County, which is United Health's healthcare provision arm, really where the doctors live. My background, I was an ER nurse, and I traveled around and cared for people in lots of different communities. And I felt like from a population health perspective and really caring for people that look like me, I was figuratively and literally just putting a Band-Aid on a lot of issues. So went back to school, went to graduate school, law school. I'm a healthcare attorney, and also the executive director. And through that experience, I created Nutrable, which is a virtual platform that connects patients to dietitians and healthy food, particularly for people who live in food deserts, to reduce that barrier. I'm sure we'll get a chance to talk about things like that. Thanks for being here. I'm excited and passionate about the topic.
Appreciate you. I had your bios. I've talked to each and every one of you, but I did not know what kind of firepower we were working with today. I think about the goal of the Advancement League and the goal now of our cause teams to really, truly deliver impact and make communities healthier, and that could range from, to Brent's point around healthier food to influencing policy. And the three of you together have the power to do all that. So we'll certainly be hopping on the call after. So if no members reach out to you, just know that I will be. So we'll kick things off, and as we kick things off, we'll still have some live participants coming in. Would ask everyone to stay muted. And for those that couldn't join, this will be available on YouTube after. So kicking things off. So population health. This is tough, but they say if you can't simplify it, then then you don't know it. And I know you all know it. So in one sentence, what is population health? And we'll work in the reversing and start with Kwame.
Population health is a that defines how easy it is for be healthy. It's really just a system that makes it. I think I said 2 sentences.
No, we got you. It kind of broke up a little bit, but I got it. I think you said population health is defines health. Say that one more time for us.
It's the system that makes it easy for the system that makes it easy for the population at large, or the community, to remain healthy, to find wellness.
Love it. Thank you. All right, Brent.
Well, I'm eager to hear Latasha.
No pressure.
Finish but when I talk about population health, I think defines, and that's a different field. We talk about population health management, and to me, population health management is essentially an art and a science of managing healthcare outcomes for a defined population, and that might mean my 6 members of my family. That might mean 100 employees. That might mean the 600,000 people who live in my city. But that's pretty much it. It's all about the outcomes of the group as a whole.
Love that. Love that. Last but not least, Latasha, pop health.
Sure, no pressure. Pop health is complex because it integrates so many different facets of health. But if I was to simplify my definition of population health, I would say it is the intersection between community, data, health outcomes, and wellness. And really what it is you're taking the data to identify characteristics of a population, and then using that data to really identify trends. Using that information to build programs and intervention to, either reduce the incidence of diabetes, or help individuals, stay away from their addiction. And so it's really about looking at a person, not just from their clinical needs, but looking at the whole person, their whole perspective. What's their social determinants of health? And what, in my role, I'm responsible for looking at clinical data, social determinants of health data, understanding trends, and building programs so that we can create access to quality care. We can create equity among community members. And so I know I said a lot of buzzwords, but like I said, population health is really a multifaceted, and you have to look at it from all of those different perspectives, because populations are complex. And so that's how I would define population health.
Spot on. I appreciate it. Thank you all. Thank you all. So, I think, many of our members, as I mentioned, joined the Advancement League and are participating in this. Of course, many of them have interest in population health, but a lot of them want to see how it's being used as a tool to make communities healthier. And as I talk to each and every one of you, you all have multiple hats that you wear, multiple jobs. So the question is, whether it be your day job or the project you're working on, or for someone like Brent that's a part of the Advancement League, how is pop health used to make communities healthier? And to Latasha's point, that's complex, but I would like you all to just simplify it for our audience. And we'll kick that off to Brent first.
All right. Well, at Wholesome Wave, our interventions don't have the same impact on everybody. It's not like if you give 100 people the same drug that they take at the same time on the same meals and everything else. We're talking about dietary interventions that change, and interventions that help you change. And for some people, that's going to mean giving you a voucher at the grocery store that you already regularly go to. For some people, that means delivering some fruits and vegetables to your doorstep because you're busy and you're far from a grocery store, but you do want to cook it. For others, it might mean giving you the whole meal already prepared, and any combination of those and other things as well. You know, all of us have some things that our doctors suggest that we do that we jump right on, and some things that we let go. If those the trick is to define or to create those interventions in a way that meets you where you're at, so that it works for you. And when you're talking about how this works in population health, you know, you're talking about a lot, as Latasha said, a diverse group of people, all with different needs. And so you can't just say, all right, everybody, we're going to put up a farmer's market here, or we're going to put up a grocery store here, and then boom, problem solved. It has to be, you know, it has to be defined. And so you need to know if the grocery store is going to be the thing that works for 80% of your population. How are you going to reach the other 20? And it's those data metrics that really help interventions thrive and tailor to meet people where they're at. Because it's not, you know, these are lifestyle things, these are decision things, these are rooted in lots of different complex, you know, there's culture, and it just doesn't work the same for everybody. And so you've got to segment and then fine tune your approach to each person.
Creativity, healthy food, using data. Latasha, what are your thoughts? What's going on in your world?
I absolutely agree with Brent. His explanation reminded me of a program that we're managing for diabetics, and really what, if I can just break down how we, you know, built these interventions, really what we did was identify all of our patients that are pre-diabetic, diabetic, or have concerns, you know, for diabetes, elevated A1C level. And really, I think what Brent was explaining is, in my world, what we do is identify their risk levels and segment the population or stratify the population based on risk. As Brent mentioned, you can't have a one-size-fit-all approach to, you know, achieving wellness. Not everyone is in the same position or has the same experiences that would lead them to be pre-diabetic. So for example, in this diabetes program, we built a registry of all of our diabetics and pre-diabetics in the system. And we segmented the population based on, if your A1C levels are really high, then we're going to pair you with a certified diabetes educator to help you with those lifestyle changes and to help you achieve health. If you're pre-diabetic, then what we're doing is partnering with a local hospital, enrolling individuals in a diabetes prevention program that is, you know, nationally known and evidence-based. And really, it is about targeting and tailoring interventions based on risk level, based on needs, and based on individual lives, right? And really knowing, yes, you want to think about the population, but understanding the individual is just as important. We want to understand what are your barriers and challenges from achieving health, and how can we mitigate those things through interventions or resources or community programs. And so I absolutely agree with Brett. I think a large piece of what I do is data driven and really capturing the voice of the community and understanding community needs. And then we build interventions, because you can't stick a Band-Aid on everything and think it would all go away. But when you tailor and target your activities, then you'll have more success in that approach.
Love it. Data as a consistent theme. Kwame.
Yeah. When I think about population health and how it fits in my world, from my experiences and when I focus on the future, my goal is to put Latasha and Brent out of business. Because we look at the goal really is to prevent people from having diabetes in the first place, and make it easy for people to be healthy. Because when we do deep dives and look at communities where you have people with heart disease, diabetes, premature strokes, and all those things, when we look at the root cause, there was something in that community in the first place that was either lacking, or there was too much of usually in a negative way, that has caused them to go downstream. And that's why when I even think about my startup Nutrable, to help to do two things: help people early on before you get diabetes, understand what you should be eating and how the things you consume impact your body. And we think about low income, think about Latino communities, African American communities. In many of those communities, the thing that's missing is the education around healthcare. And then the second part is if you taught someone, I had experiences as a ED nurse, I have patients who have high blood pressure, and I've explained, and they now understand how things impact their blood pressure. But when they leave, there's no grocery store here. The thing that they have access to at an affordable way is the corner store. So population health in my world, and even in my day job at working for Optum, it's a health insurance company. So the only way for it to lose money is for people to get sick. That's it. That's the only way to ensure that people don't get sick in the first place. And I see that as that because there are so many communities that have gaps that need to be filled. Population health today is looking at how we can bridge the gap and how we can prevent things from exacerbating. But my vision, at least for population health in the future, is to prevent those things from needing to exist in the first place.
Mhm.
Love that, man. So I think you just fired us up. I think we're warmed up now. We're a few questions in. We can start throwing some curveballs. I love that futuristic talk. So two questions. One for Latasha, but I'll start off with the one for Brent and Kwame. And that is, when we sent out this survey to 200 plus individuals, the number one rated topic was population health, right? Not number two, not number three, number one, right? But when you dive into the data and really look at kind of surveys from 2012, so surveys of healthcare organizations, and you ask the question, where will you be in regards to population health? Where will you be in regards to value-based health by now? Everyone said, oh yeah, that'll be the model. That'll be the model of care. This is the language that we'll be speaking. You'll have population health teams that are in the hundreds, not in the single digits for organizations across the world. So fast forward to 2021, we're not quite there yet. And when you dive into it a little bit further, based on my research and conversations with other leaders, it's follow the money. We're still trying to figure out how to make it make sense consistently from a dollar standpoint. So Kwame, Brent, how have you seen it work? How are you making it make sense financially? How are you paying the bills? Everybody looks good. Everybody looks healthy. Tell us, how's it working?
Brent, I'll let you go.
Oh man. All right. So I'll say a couple of things. One, of course, is a work in progress, right? And now that we're kind of talking, some ideas have come up. But the first is for the interventions that we do. What we have observational studies. A group of 100 had this outcome. A group of 200 had this outcome. A group of 500 had this outcome. And then what we do is we take NIH data to say, all right, what if that specific population that had those outcomes was extrapolated nationwide? And then you have, cost savings in the billions, but that's just modeled, right? There's no way you can have with any kind of certainty that we'll have those outcomes if we roll this out nationwide, whatever the intervention is that we're talking about, right? And that's the obvious flaw. And it's far less predictable than if you just get a pill or a vaccine to everybody, right? And so we work to bridge that big gap. One, identify the gap, and we've modeled how many billions we would save as a country with certain of our program outcomes that we found. But now the role is, all right, how do we make it more and more predictable that when we grow from 100 to 1,000, 1,000 to 5,000, that you'll have those same outcomes? And that's it. So it's about scale, but it's about not losing what worked in that 100-person program when you grow it. And that's the key thing that we're working on right now. And like I said, it's a work in progress. The second thing that has come up, just as an idea since we've been talking in these models, is that a lot of these models, not all of them, but a lot of these population health models have really kind of turned into looking a lot like the old fee-for-service model and acting a lot like the fee-for-service model. There's a lot of reasons why we continue to churn like the money-making parts of the business, and we lay off the things that don't make so much money. You won't have, maybe people will come up with a way, but you really won't have full the cost savings and the numbers work in the way that we think or what we've talked about and we kind of expected them to be working by now, until you really have that downside risk. Until when you really don't do population health management well and it really hits you in the pocket, until that happens, you're never going to have the upside rewards that you could potentially have, or at least they're going to come a lot slower. And so the people are not willing to take on risk. You know, I won it with my business, right? Everyone's trying to reduce your risk in your own business, but until you're willing to take on that risk, and governments, you know, pushes it on when there's large populations, like employers who have to take it on. Until you take it on, you're not going to see the outcomes, and I think that's one of the main reasons.
Appreciate that. I appreciate that, Kwame. Brent, totally agree. In my experience, I went from leading operations in a hospital that was mostly fee for service. And it was, like you said, you only make money if people are sick and people come and need surgeries and procedures and all those things. That's what keeps the lights on. And I was excited to join United or Optum because, as I mentioned, you have to keep patients healthy in order to make money. So it's in my day job, you keep the lights on, you make this model profitable, because the opposite of a fee for service business model, never own hospitals, and is literally put 100% investment. Optum has put 100% investment in keeping people healthy, making sure that doctors are easy to get in contact with, making sure that patients, if they live in a community that doesn't have food, make sure they partner. It's important to partner with organizations that fill the gaps for their patients, and and by doing that, the model remains profitable, because as employers and people pay for health insurance, then you're able to keep that income as opposed to spend it on hospital visits, expensive medication. We found that in order to do it was partner with organizations, and Nutrable is virtual dietitians and food delivery. So every time we looked at a market that we would enter, we're in Oakland and now Memphis. Where Oakland and Memphis are our hubs. We also have patients in Maryland and Ohio. And every time we would look at a market, initially we thought it would be hard to create an ecosystem of organizations that are already trying to do the same thing, already trying to make people healthier and offer food. So we would partner with the hospitals who were losing money because patients would have surgery, don't have the access to nutrition when they leave and get a readmission, or elderly patients who keep coming to the hospital because they're malnourished, et cetera. So we will partner with them, and we will offer our service cheaper than it would cost for them to hire their own dietitians. So it's about 50% of the cost of a dietitian, and we can see the same number of patients. So now every single patient who leaves your space has a dietitian to help them get the food that they need, help them understand the food that they need. And it just so happens that since they have that connection, they end up supporting them with other things that you need, whether it be transportation, housing, social services, et cetera. Fantastic. Hold that thought on partnerships. I'm gonna come back to you and actually dive a little bit into detail on that in context, but certainly appreciate it. So Latasha, did not forget about you. So you are a fellow as well as a PhD student right now. And you know, we always love to know what the future is being taught, right? So think about population health and all of the excitement, but also all the opportunities. So for aspiring students, master's levels, PhD students, what do they have to look forward to? What's missing? You know, we don't want to throw hop under the bus, but please do keep it real with us.
So my background is a little different. I didn't start off in health administration. I've always been a public health girl. I was a health educator, a program coordinator, managing grants, and I've always been the community person. When I graduated from Emory with my MPH, that's when I did the transition to health administration, and I got into another fellowship, a health management fellowship at Hopkins. And I felt like I was constantly on a soapbox there, constantly asking, where's the community voice in some of our activity? How do we make decision with the community in mind? And I think as I reflect on my experience in academic health, right? I think there needs to be more public health people in academic health care, right? Because we're trained, we're built, we understand community, we understand how to translate programs into measurable activity with outcomes. And not saying that health administrators don't, but it is a different craft. I felt like I was speaking two different languages when I talked about, from spreadsheets to people, right? And so I think what's missing is the public health element and population health, or that expertise in public health, because the translation of community activity to progress, that's my whole foundation. That's what I was trained to do, rather than looking at numbers, looking at spreadsheets, and the data is just as important. It does drive activity, but the action is needed behind it. And I do think there is a lack of public health people in the healthcare administration world. And having that dual perspective has definitely allowed me to translate my passion and the things I love to do and my work and find a home in population health. Population health is so complex. You have population health management, you have strategy, you have all of these different things. But the connector of all of it is community, and that's what public health is. And so I encourage people who are pursuing, degrees to dip your toe into the community, start to talk to people, start listening and translating the needs and the issues that you're hearing into actionable programs that we can measure, turn around, and show there is a financial incentive to have community engagement, right? I believe the community is the key to all solutions. And so let's put them at the table so that we can make sure, those things happen. And so if I was to say something, what's missing, it's the public health in health administration.
Certainly appreciate that. No, I think it's spot on. And I'm not sure if you can appreciate what I'm about to say, but for Latasha and for Johns Hopkins, if you're tired of healthcare administrators not, appreciating the importance of community, if you're tired of health administrators dancing all in your videos, come to the Advancement League. So we certainly agree with you, and that is a call to action for all of y'all. So a few more questions. A lot of them in the career aspect. As I mentioned, we have members that may be in the job that pays them well, but maybe looking to better align with their purpose. We have individuals that are finishing up schools, thinking about PhDs. So we'll jump to the career session. I'm going to ask you all specific questions, but I did have one specific for Brent, one for Kwame, and then we'll keep it rolling from there. And for Brent, you kind of touched on this. And the question that we get often is, we hear about the financials, we hear about the money as a barrier to truly having value-based care and population health kind of moving into the forefront. But what are some other barriers to making this topic more prevalent? You didn't come out and say it, but you headed down that path, and I know you live in a policy world, so please do let us know.
Well, yeah, I mean, I do live in the policy world, and we lean on policy a lot, and a lot of people look to policy to solving things, but in reality, like, culture eats policy for breakfast, right? It's culture moves policy. It doesn't happen the other way around. So that's one of the things I would like to like kind of level set with. But you know, when the first thing that comes to mind when you ask that question is the sheer variability of people, both on different types of people, your population, but also in the people who are delivering the intervention, you know, the community. So, and you really don't have to look further than the vaccine, right? Like for me, the convincing factor of the vaccine was FDA data and peer-reviewed studies. But for many people, it's totally different, right? And when you talk about hesitancy, it can be any number of things. It could be it's political, it could be knowledge, it could be simply uncomfortable with needles. But to Latasha's point, you know, hearing from your neighbor is the quickest, easiest way we know to make progress. And so you see cities around the country who have huge populations that they have to get this vaccine to, investing in community-rooted door-to-door knocking, right? You see them paying millions of dollars and investing a lot of the time for local governments to say, hey, go talk to a couple of neighbors, it would make a huge difference. And if you can do that at scale, you make a big difference. At some point, that's going to get exhausted, right? And so you go to, you know, celebrities to do infomercials, or maybe you ask Mitch McConnell to get up on TV again and say that vaccines are good to reach a certain other population. But it's all about communicating to somebody in a way that they'll hear it. And then, of course, once you convince them that they have to do it, making it easy to get it done. And so vaccine is a good illustration, but you got to do that with all types of dietary interventions, you know, and anything else you're trying to do for your population. You know, after you dig through that data and you identify a huge opportunity, it's about kind of connecting that in a way that people will hear it and be able to take action.
Wow, I appreciate that. You know, from a personal aspect, I was ready to blame it on the government and say that we needed more policy, but I love that quote that culture eats, you know, policy for breakfast. And I think the vaccine is a prime example. And it also is a call to action to, you know, each and every one of us, the folks listening as well as the Advancement League. So, you know, our celebrity friends, if you're hearing this, let's make community cool. So absolutely love that. Kwame, you touched on this as you talked about the work that your company is doing in the various markets that you're positively impacting. And that was partnerships. So you think about our cause team leaders, which are synonymous to chapter leaders. Each of them are focused on a different social determinant of health. And right now they're in the strategy phase, trying to figure out where to start, what market to dive into, who to reach out to. And Kwame, and I would love for you to talk about, you know, just the coolest partnership that you did, and very quickly, you know, how you got there, and, you know, just talk to us about that, because I think that'll spark some ideas for our leaders.
Yeah, so well, generally speaking, when you talk about really grassroots community organizations, and especially ones that were focusing on food, they don't have a lot of resources. They're not like open all the time. So I was looking for a partnership in the Oakland area, and there's a food bank. I see it, but it was like nobody was ever physically there. They were always out doing work, which was great. So actually one day I'm driving and I see someone there. So I like almost crashed trying to like find a park around the corner and run before she gets into the door. Luckily I had on like dress clothes. I'm just running down the street trying to flag her down. And I just happened to catch the executive director of the food bank. And the way we approach our markets is we go find the partners first, and then we bring them to the patients, because that's the point of our platform. It's the opposite of what when you generally think about our healthcare system, especially pre-COVID, that patients have to go to the doctor. Like people say, I'm going to the doctor. But for us, we wanted to bring the resource to the patient, make it really easy for them. So I found a local food bank who had them, and it was for Alameda, California. Then I reached out to the medical director for the hospital in the emergency department. And I talked about, and I showed them, hey, this is us, this is our platform, and we're here with all the food banks in the area. And collectively, the food banks actually already had resources, money, staff to provide food to any patient they wanted. The hospital and the patient, they just in the food banks just didn't have a relationship. So with our platform, our first relationship was offering it to the hospital and showing them just by doing this short thing, clicking this button. Now every single need in the hospital, you could try it. We were just like, all right, let's just randomly pick a diet. We're able to see the dietitian, see how it worked for their patients. And that's generally, we just rinse and repeat that everywhere we go.
Love that. Definitely gonna chop that clip up and get it to our leaders. I appreciate that. All right. So couple last questions for each of you, and I'll kind of call out your name. First for Latasha, because you mentioned the word community. So I would love your thoughts on this. For aspiring, students, leaders, etc. What book would you suggest today? First one that comes to mind.
Well, as a student and new mom and new role, I feel like I haven't picked up a book in a very long time. So I'll pass that on to my colleagues, and maybe they can inspire me to find a book that I can read.
Love it. Community. Anybody got a book, audio book? And if not,
one I can recommend is, and I didn't get to finish it, but I did start it, is Not in My Community. And I'm sure some of you have heard of it, but it's definitely a really eye-opening book about Baltimore City and the things that are happening in the Baltimore area, or historically what's been happening in the Baltimore area. I can't give it away because I didn't finish the book yet. So if anybody has read it, I would love to hear more about it. But that's always been, it's been on my shelf and something I've been looking forward to read.
Love it. Brent, you had one?
Yeah, so I'll go with what I just finished listening to as an audiobook, and that was Born to Run. This book is about marathon runners, but it's also about the science of running. And there's lots of great tidbits in it. But one of the thing from the book that kind of illustrates what the book is about is how kind of they've developed running shoes over the course of the years to try to get people to run longer, but it just caused more injuries. And really the best thing you could do is run as close to barefoot as you could get. And I think that's a great illustration of our medical system, right? We do all these healthcare interventions, and at the end of the day, just as many of them make you more sick than make you less sick. And I think anyone on this call would really enjoy that. And it's a great audiobook.
Checking it out. Born to Run. On it. So I guess, Brent, we'll stay on you for this one. And that is, how does a current MHA, MPH, or even an MBA student break into pop health leadership? So what's the fast track? We're trying to give people the cheat code here.
I don't have, pop health leadership is usually not in advocacy very much. And so I don't have, the space that I know is advocacy and lobbying. That's the space I know the best. And there is kind of a lack of population health management leadership here on the Hill doing this type of work. The best way to get involved in advocacy as a full-time profession is to find advocacy organizations that do Hill days. So one of the first ones I ever went to was one of the anti-gun violence organizations that was talking about a few laws that would really make a big difference in gun violence. And they need bodies. They need people to come and tell their story. And you meet directly with a senator, a leading senator on the leader of the committee or what have you. Those meetings, you meet a bunch of other colleagues, and some of those turn into jobs on the Hill. There's jobs in associations. Almost all associations have an advocacy arm. So finding those jobs is a good place to start, but you don't need to get a job. You can do it for free. You can go talk to your lawmaker about anything that you find that you're passionate about and you're knowledgeable about. They work for you and they'll hear you. So whether you go with a group or on your own, just doing it is the best way to get started.
Hey, Brent, you just inspired me. I'm gonna be emailing some senators today.
Do it.
I thought Kwame left to go put on his running shoes. I wasn't sure what was going on. Gotcha. I love that though.
I can actually respond to that if you don't mind.
Yes, please.
Yeah, okay. I have 3 things, and 2 of them are my mottos, I would say. First is network or don't work, really. I think every role that I've had in public health or community has been some sort of connection. There's so many people out there that need additional support or just want to help the next generation. And so don't be afraid to, find someone with a cool title that you may want to have one day on LinkedIn and reach out to them and say, hey, can I, meet you for coffee, post-COVID, right? Meet you for coffee or, online, and just learn about what you do, right? And try to soak up that information and learn from people's experiences and mistakes and successes as well. The second I would say is pipeline programs. I think that's the only way that I've been able to kind of fast track my career through pipeline programs. For example, the administrative fellowship that I was a part of. I can think of other public health internships that I was a part of, but having those training programs really does help you get, I guess, credit a little bit, right? You're getting exposure, you're getting experience. And so I would never, ever discount a pipeline program. And lastly, I would say, especially if you're in your graduate period, graduate school period, don't say no. Don't say no to any opportunity. You're in a point, 2-year, 4-year, whatever, where you're learning, and learning is not just in a book, but it's experience. And I think offering yourself to volunteer, to be an intern, to ask that person, can I just help you on that project? You don't have to necessarily pay me to do it, but that experience on your resume is what's going to get you in. And so try not to say no. When I was in undergrad, I know this sounds ridiculous. Part of it was survival, but I had 6 part-time jobs, as well as I was a full-time student. And it was definitely that exposure, experience, and networking that helped me get to where I am now. So I would never discount opportunity, and try not to say no. You can sleep when you're done.
We have a happiness cause team. This is all about everything you just mentioned, etc. So I may need to connect you with them, just to talk about that, and the importance of balance, and of course some things that you mentioned. I love the network piece, because I think that aligns with the community piece that you mentioned, which also supports what Brent said. So, when I look at the list of items and the questions that members submitted, you all have knocked it out of the park. Latasha, Brent, Kwame, you all are truly experts. To the folks that were able to join, we appreciate you all. Before I leave, please tell us if we missed anything. If not, please tell us how we can connect with you, stay connected, and send all of our cause team leaders your way, because you all have a ton of answers.
Can I add one thing about a book to read and how to break into population health? And they kind of go together. So I get up to go find the book. I can't remember what book I read before I started my administrative fellowship. It's just Healthcare Finance Tools for Non-Financial Managers. And it's by Judith Baker and R.W. Baker. And it's just a book that helps you understand healthcare finance. And the reason why I think that's one of the most important things that you could do is because when you look at, especially the policy space and the population health space and nonprofits, the fun thing to do that those people are drawn to is helping people and like data and all those things. But what tends to be the issue later is the financial piece. And there's so many people, and so many organizations that would benefit from your financial knowledge, that even if you don't have a lot of experience, if you understand their metrics, can understand their books, they can find a way. It's much easier for you to come and add value right away and be invited into the space to get to do the work that you want to do.
Absolutely, and that may be one that is good for you regardless of where you are in your career.
Yeah, I want to read that book.
As a
Yeah.
refresher.
What's the title of it
Yeah.
again?
Oh, healthcare
What was that title
finance basics. Here, I'm pretty
Nice.
sure they're on like the 4th edition now, but this is it by
All right.
Judith and R.W. Baker. It just like understanding that, it just building on that over time has been extremely helpful in my career.
Love that. Appreciate that. Fantastic. I see some contact information flowing in the chat, but would also love for you all to just say it to the camera. Social media, LinkedIn, please do drop it. We'll start with Brent, then go to Latasha, and finish with Kwame.
Yeah, on LinkedIn is a good way to find me. Brent Ling, and I'm with Wholesome Wave, and the message tool on LinkedIn is a great way to find me quick. That buzzes my phone. So I also put my email in the chat, brent@wholesomewave.org, but I'm sure to see the LinkedIn message before an email.
Yeah, same
Nice.
here. I added my personal email to the chat. That's barnwell.latasha.drph@gmail.com. And I'm also available on LinkedIn. And so feel free to reach me either way.
Awesome. Thank you. Kwame.
And it's Kwame Liddell on Instagram, Kwame Liddell on LinkedIn. I put my email, kliddell@dispatchcare.org. You'll find always working on something that's going to positively impact the community. So if you have ideas and you want to innovate things, feel free to reach out.
Awesome. Well, it's been a pleasure. We appreciate you all.
Shameless
Yes,
plug.
go for it.
One last thing. I'm sorry. I am recruiting a site administrator for Optum Orange County. If you're interested in population health and you want to run a physician practice and specialists that are 100% incentivized to make people healthier, reach out to me. Let me know.
Love. You're gonna motivate us to put this up tonight. Get some folks in your DMs to get that, man. Appreciate you all dedication to community, to this work. Shows day to day, but shows what you all being on a call in these evening hours, during a pandemic, because we all still in a pandemic, and when we're seeing the number trickle up. So y'all stay safe, stay blessed, and continue to pour into our communities.
Thank you.
All right, thank you.
Take care.
Bye.